Hello, everyone, and welcome to the April 2024 UCLA Tarjan Center Distinguished Lecture Series. I'm Dr. Jasper Estebillo, Director of Training for the Tarjan Center, and it's my pleasure to be here with you all today. A couple of reminders before we get started. For live Spanish interpretation, click on the interpretation button on the bottom of your Zoom toolbar and select Spanish for interpretation. For simultaneous cart closed captioning, click on the link set in the chat to begin viewing the screen text. Please also enter your questions for our speakers into the Q&A throughout the talk, and we'll facilitate discussion at the end of the presentation. And after today's lecture, please complete our evaluation survey to provide feedback and suggestions for future lectures. The link to the evaluation survey will be sent in the chat today, as well as in a follow-up email tomorrow. And with that, I'll hand things over to Dr. Liz Lockeson, Director of the Tarjan Center, to introduce our speakers.
All right, well, thank you so much, Dr. Estebillo. Good morning, everyone. As Dr. Estebillo mentioned, I'm Liz Lockeson. I'm the director of the UCLA Tarjan Center, which is our University Center for Excellence in Developmental Disabilities. And on behalf of the Tarjan Center faculty and staff, along with our co-sponsors, which include the UCLA LEND program, our UCLA Center for Autism Research and Treatment, the UCLA Intellectual and Developmental Disabilities Research Center, and Fiesta Educativa. It's my pleasure to welcome you to our distinguished lecture and to our distinguished panelists. Our first panelist today is Dr. Nurit Benri. Dr. Benri is a postdoctoral fellow in Dr. Kathy Lord's lab at the UCLA Tarjan Center and UCLA CART. Dr. Benri is interested in the implementation of evidence-based interventions in community and school-based settings as a means to reduce disparities in access to quality care. Dr. Benri is conducting bilingual autism assessments as part of the study that you'll be hearing about today. On a personal note, I had the pleasure of mentoring Dr. Benri when she was a pre-doctoral psychology intern in the Autism and Neurodevelopmental Disabilities track here at UCLA, and we are so happy to have her continue her postdoctoral training here at UCLA. Also on our panel is Nicole Rosen. Nicole is a fifth-year doctoral student at UCLA, also working under the mentorship of Dr. Kathy Lord. Nicole's research interests include examining the role of siblings on development in autism and improving access to care for underserved populations. She's also conducting bilingual autism assessments as part of the study you'll be hearing about. And I've also had the pleasure of knowing and mentoring Nicole for many years, even dating back to when she was an undergraduate student at Washington University. And I can attest to the fact that she's a brilliant researcher and clinician, and certainly a rising star in the autism research community. Our third and final panelist today is Myra Tafoya. Myra is a fourth-year doctoral student at UCLA, also working under the mentorship of Dr. Kathy Lord. And Myra is interested in understanding and supporting the experiences of bilingual, low-income families of color with intellectual and developmental disabilities related to diagnosis and service acquisition. And Myra is the coordinator and co-investigator of this study. So we're very excited to have our panelists here today to present on the autism diagnostic process with a bilingual low-income Latinx community. They'll be examining barriers families experience and what providers can do to help. So please join me in welcoming our distinguished panel.
Thank you so much, Dr. Lockeson. I will go ahead and share my screen and hopefully you guys can all see this okay. I just realized that I don't have that fancy background slide, but I'm just gonna go ahead and assume that's okay. So thank you all so much for being here. Again, my name is Myra, and I am going to be getting us started. I'm going to be providing a brief introduction to this larger project that we are doing in the Lord Lab under the supervision of Dr. Catherine Lord. Because today we're actually going to be talking to you about our experiences in doing the study so far, with about 70 families that we've already seen. So we're going to be focused on, things that we have learned from these incredible families. And these are going to be the learning objectives, which you guys have heard already, that we're going to be spending most of our time talking about. But before we jump into those, as I mentioned, I'll just provide a brief overview to the larger study. And so the two objectives are to identify some of the barriers that bilingual, low-income Latinx families in the greater Los Angeles area and really all across California, which we can discuss later. The barriers that they experience related to early diagnoses and service acquisition. And then we're also going to be talking a lot and spending most of the time talking about strategies that providers can use to support these families. So I'll just jump right in. I'm sure many of you know what autism spectrum disorder is, but just very briefly, it is diagnosed based on challenges in social communication and interactions and in restricted and repetitive behaviors and interests that present early in development. And so here is a slide that I personally really like. It's a really good reminder just of what a high quality comprehensive autism assessment looks like and what it includes. And this was kind of some guidelines provided by Kathy and some of her colleagues. And the first one is a direct observation of the individual being assessed. And then caregiver and teacher provider, whenever possible, interviews and questionnaires that capture these range of behaviors, either currently or, from early on in development. And then finally, cognitive testing just to get a baseline of the individual's abilities and challenges on a standardized assessment. And so the ADOS falls into that first, that first group of the direct observation. I'll go back here briefly. And the ADOS, or the Autism Diagnostic Observation Schedule, second edition, is a clinician administered, standardized, and big emphasis on the semi-structured observation that is used to capture behaviors that can help us inform a diagnosis of autism. And going forward, I will be referring to autism spectrum disorder, ASD, as just autism. And so the ADOS has different modules. There are, for this project, we're using 5 modules: the toddler, module 1, module 2, module 3, and module 4. And if that doesn't mean anything to you, that's okay. They're just different modules designed for different age levels and for different language abilities. It can be used in different contexts, and it often is, such as schools, clinics, and we will be talking about I don't know if it's a newer context, but a more unique context, which is the home. And the ADOS has been translated to many different languages, including Spanish. However, it has not been validated with a Spanish sample, and I'll get into why this is important. And so the Latino population in the US is the largest minority, and Spanish is the most common language other than English. So what this means is that many individuals are bilingual, and also that there are a lot of autistic individuals who are likely bilingual. And bilingualism is a really complex construct. There are too many primary ways that are used to classify bilingual individuals, including simultaneous, and sequential bilingual. So that means you either learn two languages from birth, you were exposed to both of them, or you learned one language and then picked up a second language in school, which I think is very common, especially here in Los Angeles. And with that was the case for myself. I first learned Spanish, which was my home language, and then learned English in school. And a lot of the literature on bilingualism in ASD has been primarily cross-sectional and has focused on comparing language abilities between bilingual and monolingual individuals. And the reason for that is, there used to be this belief that learning two languages or exposing your individual with autism to two languages would confuse them and would hinder their language development. However, the literature now, this cross-sectional literature does not show that that is the case. And there is limited research on the use of the ADOS with bilingual populations. So that kind of brings us to the current study, which I will introduce using a hypothetical case. This is something that many providers experience, especially in urban locations like Los Angeles. And so the hypothetical case is a family of a child who is 24 months old is referred to a clinic to be assessed for autism. Parents speak mostly Spanish, and the primary language in the home is Spanish. The child is attending daycare where he or she is exposed to both Spanish and English. The child's older siblings speak both English and Spanish with each other, and the child is exposed to English on his electronic devices. The child speaks in single words, sometimes using Spanish words and sometimes using English words. And so the clinician is unsure about how to approach the assessment of this patient. Should they do the assessment in English? Should they do it in Spanish or refer out if the clinician doesn't speak Spanish? And or should they do it in both English and Spanish or refer out to someone who can do both? Before I had option D to include a translator, but that is not something that we recommend or is ideal. So I took it out just so that we don't focus on that here today, because we won't be discussing that as much. However, there are some logistical issues that arise with including translators. It could potentially, delay the time that this individual is on a wait list if you are looking for a translator who speaks a specific language, and also just thinking about the logistics of being in the assessment room and as a clinician having to say something and then waiting for the translator to pick it up, say it either to the child or the parents. As you can imagine, it kind of brings up a lot of different issues. So then that brings us to our research questions, which is again for the larger project. And the first question is, will the presentation differ depending on the individual's dominant language? So if they speak Spanish or English primarily, and the language that the ADOS 2 is administered in. And then our second research question is, will bilingual individuals be correctly identified as autistic if the assessment is done only in English or in Spanish, also depending on the language that the individual is most comfortable with, or their dominant language. So our goal is to recruit about 100 participants from early childhood to adulthood with different expressive language levels. We have been very lucky in that there has been a significant amount of interest in the project, and we have already seen about 70 families. So today we're going to be focused on, talking about those experiences with those families. And I will pass it over to Nicole. And Nicole, just tell me when to go next.
Perfect. Great, thank you. So in thinking about how we were able to recruit these 70 families thus far, and our plans for continuing to recruit to get to that target number of 100, we've really been recruiting through schools in the Los Angeles districts. Regional centers have been really helpful. Different autism associations. We've been working with a few different community nonprofits who specifically work with Latinx populations across LA. We've also been fortunate to have the Center for Autism Research and Treatment, CART, at UCLA, and the Tarjan Center, who both have kind of growing lists of potential participants who have consented to receive information about ongoing research studies at UCLA that might be applicable to them. And we've also been able to attend different autism resource fairs that have generated some interest, community-based clinics, word of mouth, lots of different options. But I think just something that at least I found really interesting is we've been contacted and have been in contact with groups outside of the Los Angeles area and in San Diego, in Irvine, in the Inland Empire. And I think all of it really just shows there's so much interest and so much demand for services like this and studies that are kind of using Latinx populations and including them. And it really just shows that it's such an untapped research asset that we and a group of people who really want to participate in research who maybe have not had the opportunity to do so. So just a plug there to continue incorporating this population in research. But this is our kind of current recruitment strategy, and it has thus far resulted in about 70 families. Okay, so very briefly, and we are happy to give more information about this if anybody is interested, but the strategy that we have been using as part of this study is we are administering these assessments twice. So each individual is randomly assigned to either receive an English or a Spanish assessment the first time, and then they'll get the opposite one the second time. So everybody will receive a Spanish and an English assessment. Just the time that they get the Spanish one will differ based on that randomization process. They'll also be randomized to who actually does the administration of the assessments between Myra, Nurit, and myself. And in thinking about what these time kind of sessions look like, we cover cognitive assessments, the ADOS-2, as Myra described, the BESA, which is the bilingual English-Spanish assessment, which really just gives us information about language dominance and kind of the settings in which people use these different languages. And then the brief observation of symptoms of autism, and that's a similar kind of semi-structured social context that uses standardized materials, kind of similar to the ADOS, but it's typically administered by caregivers and coded by us that just gives some important social information. And then at time 2, they'll get whatever other language in the BOSA. And time 3, we included that piece because that's usually when we give feedback to the families and give them reports to really summarize what we've found. Okay, and now we will move on to kind of the bulk of this presentation about just what are the findings, what have we learned from this study? So first things first, I think it's really important to highlight the barriers and really emphasize that we understand. And I think this is something that most researchers who have been working with the Latinx population in autism assessment and treatment have heard. But this is just a summary of things that we've been noticing as trends from speaking with these families. So first, limited access overall to evaluations and services. I think this is not surprising and a really stressful and unfortunate thing that's happening. Tons of participants have mentioned just incredibly long wait lists, 2 to 3 years. And while 2 to 3 years might not sound like too much, 2 to 3 years during that kind of really important developmental period is an incredibly long time. And access to evaluations really are kind of the starting point for access to services for a lot of these families. So these long wait lists are really difficult and are really prevalent. And then also just lack of availability across the board. And a lot of this also factors in costs, because when we're thinking about, there can be evaluations available, but if they're not accessible because of cost or location or other factors, that's a limited access, and that really kind of hurts the family and the child in getting access to services. And then there's this piece of misinformation, which I think we found really striking, and it's misinformation across the board. So I'll go into kind of a few different areas that we've really noticed a lot of families reporting on misinformation. First, in the sense of the age of diagnosis. So we've heard from many families that providers have often told them this kind of magic number of age 3, which is when these providers have apparently told families that kids can only be diagnosed at age 3 or later. And the kind of problem with this idea is there's a critical window that a lot of these families are missing out on when the autism is clear, or parents are noticing these differences and these challenges and feeling like something is different. But when they're told that assessments can't happen until age 3, they're missing out on a critical window that services could have been in place to get the ball rolling. And also, when we think about, it's not just about getting services in that moment, it's also thinking about them not being able to get the process started at that early enough time point when it's actually available to them. So when they start school, maybe the services could already be in place to set the child up for success and starting school at that 3-year mark. Maybe they could have been able to get the IEP going. All of those things that kind of could have maybe prepared the child, set them up for success a little bit better. Then we think about levels of ASD. Lots of families have come in and said something like, my son has level 1 autism. And then we see them, and this child is actually more impacted than we would think from having heard that comment about a level 1 autism diagnosis. And we, in thinking about that, we have to really kind of question, where does that level 1 come from, and what does that actually mean? Because the meaning can be different for different people. We know it was originally created for providers to try to kind of understand service needs, but that's not really how it's being used now. And it actually has been harmful for a lot of these families who report kind of a misinformation regarding that level of ASD. Also, strengths and challenges. So when we think about how these families have described previous evaluations or just comments that they've heard from other providers, their comments often focus on the label of autism rather than the specific strengths and challenges of the individual. And as everybody I'm sure knows, autism is such a heterogeneous diagnosis with an incredibly wide spectrum of presentation. So the label really in itself does not provide enough information. Those specific strengths and challenges are really needed to better understand what is it that my child can do well, and what is it that my child needs extra support in being able to complete. Language level, this I think has been something challenging for assessment purposes, but a really interesting observation where there's often a discrepancy in the language level that's being reported by the caregivers on those initial recruitment calls, and then the actual presentation of the child. And this has happened in both directions. So we're thinking about maybe caregivers saying that their child only speaks in single words, and maybe even rarely, but then the child comes in speaking in full phrases. Or the other way around, where caregivers report that their child is speaking in full sentences, but in reality, these sentences are scripted. Or maybe the child is really only spontaneously and flexibly speaking in single words or simple phrases. And a lot of this really stems from these kids not getting follow-up evaluations, or this lack of continued care to get an updated profile of the child's language, because maybe they did have that level of language during the first round of assessments with providers or during their first appointment or session with a provider, but these skills change over time. And so really highlights the importance of continuing to get updated care and reevaluations to better understand how these kids are developing. Another barrier related to the lack of follow-up evaluations is often kind of an absence of co-occurring diagnoses. And specifically in this study, what we've seen is numerous cases where we are the first to potentially put the presence of an intellectual disability on the parent's radar, or at least mention concerns around this and things to note and really track. And this is something that is really important because there's a lot of different ways that we can modify services and adapt services to be more appropriate for the child and for them to really thrive in the services that they're receiving. And having this kind of identified co-occurring diagnoses are really important for having that child kind of be put on a path for success and whatever success might mean for them. Lastly, these pieces of service acquisition, what are families actually able to access? A lot of times these families are given recommendations for services that are not available to them. They're not accessible around them. They maybe cost too much, lots of barriers in what they can actually access. And finally, this piece of the time frame that we are in, where we are kind of post-pandemic or post most of the pandemic, we're seeing some of these pandemic babies or other kids who had COVID really disrupt an important part of their development. And during COVID, a lot of these families received virtual assessments that understandably maybe were not as thorough as those that would be completed in the clinic. And some information is missed. And this acts as a barrier too, where we don't have as much information on the child. The parents don't have as much information on the child, or maybe the information isn't as thorough, picking up on the difficulties with adaptive functioning and not really exploring certain things that are important parts of a child's profile and that really have important impacts on services moving forward. And now I will pass it on to Nuri.
Thank you, Nicole. Yes, so now I'm going to shift and to speak about what we as providers, like what can we do? And I'll be talking about both things we can do in a clinical setting and also in regards to research. So when we'll be talking about our recommendations, we'll be talking about things, always keeping them under the lens of being with cultural sensitivity in mind. And what we mean by this is really thinking about and having knowledge and awareness, and also our willingness to really understand other cultures, and then having that influence the way that we approach other families. And especially given all the misinformation that Nicole has discussed that these families are experiencing. And of course, our recommendations are not exhaustive, so we really will only be scratching the surface. But as clinicians, we really want to be aware of having our information be something that is accessible to the families. So when we're thinking of this is really using language, ideally being able to communicate information in the primary language, and we know that that's not always the case. So then if we are writing recommendations or giving reports, either having a copy that can be translated into the language of the participants we're seeing. In our case, we will often write recommendations in both English and Spanish so that the parents can use the report that is written in English and give that to the school and the regional centers, and then also have recommendations that are in Spanish and written in a way that are accessible to the family. So really trying to not use a lot of jargon and writing things in a way that the family is going to be able to understand and use. And we will talk about our feedback and recommendations a little bit later on. Also just being mindful about the materials that are being used. With the ADOS, many of the materials have been adapted to be more culturally sensitive. And just qualitatively, out of the 70 participants we have seen thus far, no one yet has brought up any concerns about the materials. And an exciting piece of the study will be that we're going to be conducting phone calls after the assessments to really get a sense of the family's perspectives on the assessment, and then also the feedback, and then also continuing to evaluate any barriers or access to care following our assessments. We also want to be mindful when we are having families fill out clinical questionnaires. Often we're tempted to want to send questionnaires before we see participants so that they can fill them out ahead of time or fill them out online. In our study, we have really found that families sometimes prefer to fill these out in person or to have hard copies. So we really have gone above and beyond by like either dropping out physical forms at people's homes and or having allotting time to fill out questionnaires when we're scheduling with families. And then also we want to be mindful about consenting and also compensation. And this is especially has come up a lot in research. Like, for example, with our study, when we were thinking about compensation, initially we thought about compensating families through using Amazon links. However, a lot of families have mentioned that this is not a preferred method, and it was really adding on burden, and like that they didn't know how to access the link or didn't really use Amazon. So really just being flexible has been something that we have learned while also trying to be as culturally as sensitive as possible. And yes, so now I will talk about some of the key things that have come up in ways that we have adapted the way that we communicate with families. And again, flexibility, you'll hear us talk about a lot, but as I mentioned earlier, just really ensuring that the communication is being delivered in a way that is accessible to the families. So that is about the language that it's being used and also the formality, and also understanding where the family is coming from. So understanding their understanding of the assessment and any psychoeducation that would be helpful for the family. With our study, phone calls has been the preferred mode of communication for these families, as well as text. Emails are used, but not preferred. So for us, just really being flexible in finding like the mode and then also the time of communication has been really helpful. We're aware that like with some in some clinics, the time constraints can make it that it's less flexible, but really finding hours, like if participants or families are really working 9 to 5, maybe shifting your hours like one day a week so that it's like 11 to 7, just really trying to work with the families. And then for us, really letting participants call in, or like for us to meet participants in different locations has been very important. And then also being responsive and just really maintaining that open line of communication has been really critical. Yeah, so flexibility in general has been key to really being able to meet these families. So for example, oftentimes while we're assessing, there have been siblings that are present during the evaluation if parents are unable to get childcare. So really being flexible with that. We tend to bring some extra toys and or snacks for the siblings. For different pieces of the evaluation, we do a portion where we'll have the parent and the child play. So us looking after the sibling while that is happening. Also being really flexible with the location. So these are a few of the pictures of that kind of show all of the different settings where we have been seeing families. And we are aware that a lot of the time these settings may not be like the ideal clinical setting, but really meeting these families where they are. And it's been really interesting to see that despite the locations maybe not being the ideal clinical setting, we have it hasn't really gotten in the way of us being able to carry out these standardized evaluations, and we're still feeling really confident about the diagnosis that we're giving and recommendations, even if we are doing testing in like the park, or we've seen a lot of families in the library, in their home. And also being mindful about the timing. So oftentimes we are seeing families later in the evening, so understanding dinner time. And if dinner time is really important for the family, being flexible and taking a break, having them do dinner, and then us wrapping up the report, the evaluation after that. Great. So now I'll pass it over to Myra, who's going to talk more about the specific feedback we give to families and also how we communicate that to them and write it into reports.
Yeah, thanks, Nuri. And then I did want to just go back to one point about the flexibility piece, just because this is something that we talked among ourselves so much. And we had a lot of discussions about, where do we draw the line in when the ADOS becomes like not standardized versus when it still continues to be standardized, even though, siblings are coming in and out of the frame, or they're, coming in during free time and playing with some of the toys. And I think all of that is something that the three of us have experienced, Nicole, Nuri, and me, and we've had extensive conversations with Kathy, with Dr. Lord. And I think, it's okay to be flexible and for those things to happen. I think the ADOS really does allow for things like that to happen. Because it is semi-structured. So it's okay for sibling to come in for a sec, and then maybe you redirect them somewhere else and say, hey, we can play later. You can recruit the parents to help you. Take them out of the frame. Or sometimes I know Nicole was telling a story where, there are different adults in the household. So maybe at some point, mom is the one present during the ADOS, especially for the toddler module 1 and module 2, where an adult is required. But then she has to go and take care of something. So then dad steps in and he's the one that is present, and then maybe dad has to leave, and then maybe an older sibling steps in. And I think this is all to say that that is okay, and that this doesn't unstandardize the assessment, and that we can still get really valuable information. So now I will shift into talking about our feedback sessions. Again, this is, I think, been a learning process for all of us, and we are very lucky to have Dr. Lord as our supervisor, and she, has a lot more experience with this. So we've really taken advantage of using her as a resource when doing these feedbacks. But some of the things that you've already heard is the language that we're using, so making it really relatable. It's really easy to get caught up in the super jargony terms, because this is what we learn, right? When we're learning about autism as providers, we're learning the jargony terms. So then, I don't know, maybe practicing with your family members and delivering a feedback and asking, okay, did any of that make sense to you? If not, maybe I need to adjust the way that I'm saying things so that families can really understand the information that I'm providing to them about their child or adult. Really focusing on, I think this is something that has already been touched on as well, but not just focusing on the label, the diagnosis, I think is really, really important. Really talking about what were some of the strengths that you observed during the ADOS. Did, the individual smile? Did they spontaneously ask questions? Did they seek to interact with you? And then also thinking about some of the challenges, it was really hard to engage them. They got really frustrated and started throwing things. And I think that is particularly important because those will become the targets of intervention or just strategies that families try to work on in the home. Having concrete and individualized recommendations is so important. I, being at UCLA and working with a ton of other providers, we see all sorts of reports whenever families kind of come in to see us at our clinic. And we've seen, reports with 10 pages of recommendations, which is really great because, you want to provide all of all of the possible things that could be helpful to this family. And I think they're really well-intentioned. I think what ends up happening is that they are not always very legible for families, and things just get lost when there's such an extensive list. And that is why really identifying those that are going to be important to this family now and in the next year or two is so important. And also calling the providers that you are listing on on your report, I think is something that we've kind of run into, where we've seen reports and there's providers, and so then families come to us and they're like, hey, we really need help getting access to these services. So we're like, great, there's a list here, we will just call them for you and we'll set it up, right, to reduce that barrier. And then unfortunately, what ends up happening is that these phone numbers are not updated, or, you call and they're not seeing patients at the moment. They have a 2-year wait list. So just being, again, it does take a little bit more time on our part as providers, but I think this really goes a long way for families when you are having conversations with them too, and asking, what is a priority for you? What do you want for or with adults too, what is a priority for you for treatment? What would you like? And that way you can really invest that time finding those recommendations that are going to be suited to their needs. And then emphasizing reevaluations is so important. I think there are a lot of barriers just to getting that first evaluation alone. So thinking about reevaluations can be challenging. But we've seen adults who had their evaluation when they were 3. And then of course they had updated little things here and there as part of, their IEP or as part of the regional center reevaluations, but they haven't had a truly comprehensive re-eval to talk about updated strengths, updated challenges, and talk about, okay, what's next? What recommendations would be helpful at this point in this person's lives? This is especially important for young children, who are developing and learning. I think we recommend about every year or two, you should be able to measure that progress to see what their development is looking like. But also for school age kids and adolescents and adults, they're transitioning at different periods. So how can we as providers support them through these reevaluations so that we can provide different recommendations as they do transition to that next phase in development? And I think what, we've learned from families is that they are just shocked sometimes when we even make that initial call, because there have been some cold calls where we just pick up and say, hey, we have this really cool study, it's free, you might be eligible. And then we explain to them what it is, and they're like, why would I want to do that? I already have a diagnosis. So again, just reemphasizing the importance of reevaluations. Here's a sample of a recommendations list. This is not to say that it is perfect. This is just to highlight that we try to finalize the report first and then jump on a feedback call with families and really walk them through every step of the way. So this means maybe some psychoeducation, adapting the feedback to that family's needs. So is this a first-time diagnosis? Okay, let's get you set up with a regional center. Great, let's talk about an IEP, which is going to come, when your child turns 3, but you can start thinking about it before. ABA, what is ABA? What does that mean? Who provides that for you? Where do you request it? Same thing for speech and language services. And for PCIT, I think I really like that PCIT is in here because for this specific family, because this is a recommendations list that we provided for a family, it was available in their geographic location, which was great. So we're like, amazing, let's include it. However, if I'm talking to a family and I do some research about, where they live, what kind of services are available there, and if there isn't anywhere that or any provider who's doing PCIT, I probably won't put that on the list because it might just add a little bit of burden to this family and thinking about this additional services that they need to get, but that is not available. So again, just being mindful of the family's needs. And then the last thing I'll say on this slide before moving on is also not writing families out and thinking, oh, well, I'm not going to recommend this because they don't accept insurance and it's too expensive, right? Talk to the family, see what they are able to afford because maybe it is in their budget. So not assuming that they can or can't afford it based on their socioeconomic status. So really talking to them and letting them be the ones to make that choice. And then this is a different recommendations list for an adult. And after talking with her, she said, I'm not really interested in this or this. I don't want to join any extracurricular activities. So then I was like, great, I won't invest my time in looking for different activities for you to join. I'll just focus on the things that you were telling me that you would really like to get support on. I'll finish up with some myths, and this is, more geared toward providers. But there are a lot of myths about the Latinx population that are not anyone's fault. They've just kind of developed over time, but I think they're important to think about and to keep in mind. And that is that families aren't committed or that they aren't looking for services because there's stigma, for example, in their culture, and they don't really want a diagnosis or they don't really want to access the services because based on our experiences with these 70 families, all families have been so committed and they are just going above and beyond to get their individuals, their children or adults, the help that they need. And also for researchers, families do want to participate. It's just really important the way that we engage them. And then also a quote that I heard from a provider is that families think that speech therapy time is a time for them to vacuum or wash dishes. And you know what? Maybe it is. Maybe that is the 1 hour where they get to do this thing. However, if you as a therapist think it's really important to have parents join you in the during the one time that you're doing therapy, then tell them, just ask them, because I bet if you did, they would not say no. And I will finish up with a shameless plug. We are still recruiting participants, but we are particularly focused on recruiting adolescents or adults who can speak more fluently and are dominant in Spanish. So this might be, people who have recently or more recently immigrated to the US and are now learning English as their second language. It has been a little bit harder to find them, but I know they are out there. So if you know anybody who would fit that kind of description, please send them our way. And here is our final slide. Special thanks to the families and to Dr. Lord. This project would literally not be possible without her guidance. And also thank you to WPS for their support with the materials. And special shout out to Juliet, who's not able to make it today, but she has been incredible and so helpful on this project. If you have any questions, thoughts, concerns, please feel free to email me. There is my email. I will leave this slide up for a sec and then we can jump into questions, I think.
All right. Thank you so much, Myra, Nuri, and Nicole, for sharing about your informative and very important work. I can see just based on the participation in the Q&A and by the number of registrants for today's talk that this is very high value for our community. So thank you for sharing about this project. Reminder for our audience, please continue to submit your questions for our panelists into the Q&A function. I'm seeing a couple typing in there, but I'll start things off. I really appreciate a lot of the very concrete recommendations on what to do. But if you three could, had to prioritize and say, like, what are the top recommendations for us as providers to increase access for these families in the Latinx community? What would you say would be the most important things that we could do?
I can, or Nicole, do you want to start us off?
Sure. I think the biggest takeaway, if I was going to just summarize it into one word, would just be flexibility. I think everything really boils down to flexibility. I think all of us are, as providers as a whole in this field, I think people want to make things accessible, and I think it's a wonderful thing. And I think what this project really has shown us is that it's possible to provide these services for these populations that maybe have not been included in research as frequently, or that there's a lot of myths that are very untrue. But I think the big takeaway is, with flexibility across the board, we've been able to really access these populations and provide strong care. And yeah, so just a plug for flexibility across the board. And I think that's the main piece.
Nuri, anything that you'd like to add to?
Yeah, and I think that flexibility, and then also working with the families. I know that with discussions like Nicole and Myra and I thought that families would really prefer the testing to be done in a home setting. We were like, this is going to be ideal because it's going to cut down commuting time, and this is what families will want. And that really hasn't been the case. So we've been very flexible and working with the families, so really hearing what the families' needs are, what their concerns are, and approaching them in a way that will be accessible to them.
That's great. And how about you, Myra? What would your top recommendation for those of us here in terms of supporting these families?
I think just putting yourself out there and putting your information out there. I think families do want to learn more and access the information, but I think a lot of the times there's this issue of like, how do we reach them, right? And just very briefly, I'll say, I know we got an email about the self-determination program, and somebody saying, we've had a lot of a really difficult time reaching families. And they're hesitant to participate. And then in our conversations with families, I think they're a little bit scared. I think there may be some just misinformation going on about what self-determination is, for example. They're like, oh, well, where's this money coming from? What is the government then going to do with like my assets? So just really reaching families and providing the right information in a way that they can understand and digest it.
Absolutely. Yeah. So flexibility and just communicating openly, as well as just dispelling a lot of these myths on both sides, I think are really great, actionable things that we can do. I think I definitely agree with you about the flexibility aspect, but oftentimes for many of us providers, the flexibility, or the inflexibility rather, comes from the systems that we work in. And I think that that's the biggest barrier across the board for all of us. Do you have any reflections? I know, of course, I would love to say we're going to solve all these problems here and now, but do you have any reflections or insights in terms of how we as providers or even families can push back on a lot of these systems being so stringent or strict, or all of those kinds of things? Any lessons learned on that aspect?
I can start us off, and I just have to absolutely agree that we are in a very different position with this project, because it is part of research, and again, just Dr. Lord, who's our supervisor, has been so flexible in what she has allowed us to do and kind of the resources that we have also invested in this project. I think just some strategies and getting us all to think about it is, you don't have to change your entire work week and, work on weekends because that's also not feasible all the time. But I think Narit mentioned, like, yes, maybe you can arrange so that one of the days you come in at like 11 p.m. and you work a little bit later. And I think it is a little bit of a sacrifice that we as providers have to do and have to make. And yeah, just continuing to push back on in the systems that you work in and say, hey, we're really missing out on seeing these families who really, really desperately need us that are falling through the cracks because of this. Is there any way? Is there anything that we can do? Sliding scales are great because then you can reach more families as well. But I'll stop there. And
I would also just highlight training, because I think that's another avenue through which we can increase access. If these families don't have to travel to us from 2 hours away, 3 hours away, 4 hours away, and we don't have to travel to them, if we have kind of stronger training in these areas where they're located and increase access to services through that way, I think that would also be helpful. But again, there's a lot of time and effort and money that goes into it, and it's really just making it a priority. And we've, like Myra said, have been really fortunate to have that be the priority of our lab too.
Yeah, and then also, unfortunately, we're not going to solve and change these systems, but really knowing that one small thing that we as providers can individually do, and if we're all making these small adjustments, then collectively they do have a huge impact. So not letting the, I don't know if the word is fear, but knowing that the systems will be hard to change, but the little things that we do and that are in our control can really have extremely impactful impacts for these families.
I agree. And I think for parents and families who are in our audience, something that we've talked a lot about in the Tarjan Center lately is that participation in research is representation, is inclusion, and means that you're passing along your experiences to researchers who can then publish this data and fight against a lot of these systems that are ineffective and are not allowing us to really be flexible or do all of the work that we would like to do. So that's a plug on my side for participation in research. And I know I see a lot of questions here in the chat, but I would encourage our participants to please contact our wonderful presenters here at the email address that's included on the screen. Any last minute plugs, or maybe Myra, we can also put up that slide with the recruitment, since I know that there's lots of families and individuals in our audience who would love to participate or receive more information. I'm seeing a lot of questions about different areas in California, if they're able to participate. And so audience, please direct all of your questions to our wonderful panelists here. We are now hitting up against time. So I would like to just thank our presenters, Dr. Benry, Nicole, and Myra, for being here today and sharing about your experiences and your very, very important work. Thank you to our audience for being here today. And we look forward to seeing you next month at the May Distinguished Lecture Series. Thank you, everyone, and enjoy the rest of your day. Bye now.